Good afternoon, everyone. Thank you for joining us today. My name is Ruthie Marker, Education Program Manager at the Allergy Asthma Network. I'm delighted to welcome you to this afternoon's CME accredited webinar. We have an excellent program planned focused on nasal polyps and asthma. Before we start today's program, I'd like to cover a few housekeeping details. Everyone will remain muted during the webinar to minimize distractions. We will also record today's webinar and upload it to our website in about a week. You can also watch all of our other recorded webinars at allergyasthmanetwork.org. Our webinar is scheduled to last 1 hour, and there will be time for questions and answers at the end. Please feel free to submit your questions through the Q&A box located at the bottom of your screen anytime throughout the presentation. A team member will be monitoring the chat if you need any technical assistance or have any questions. We will do our best to answer as many questions as possible before we finish up today. This Advances webinar is brought to you in collaboration with the American College of Allergy, Asthma, and Immunology. The college offers continuing education credits for physicians and attendance credits for all others. You can create a free FAAAAI account to earn CME or attendance credits for this Advances webinar through their member portal. All attendees will receive a certificate of attendance. Please note that no other continuing education credits will be provided. A few days after the webinar, you should receive an email from Zoom with supplemental resources as well as a link to the recording and a link to download your certificate of attendance. We'll share that also towards the end of the presentation in the chat. Today's webinar is titled Rhinosinusitis, Nasal Polyps, and Asthma, What to Do. Research indicates that rhinosinusitis affects 5 to 12% of the global population, and among those with chronic rhinosinusitis, 25 to 30% also have nasal polyps. Often rhinosinusitis is accompanied by nasal polyps, which are benign growths that obstruct our airflow. And asthma often worsens in patients with rhinosinusitis and nasal polyps due to the shared inflammatory pathways. It is my pleasure to introduce our presenter today, Dr. Andrew White. In today's session, Dr. White will discuss advanced diagnostic techniques, contemporary pharmaceutical treatments, surgical interventions, and the role of biologics in managing refractory cases. Dr. Andrew White is a board-certified allergist and immunologist who provides comprehensive care for patients with allergy and immune-related conditions. He treats a wide range of concerns, including asthma, hay fever, eczema, food, and skin allergies. Dr. White also specializes in diagnosing and managing immune deficiencies such as common variable immunodeficiency and other disorders that increase infection risk. His clinical expertise extends to chronic sinusitis, nasal polyps, and aspirin-exacerbated respiratory disease. He has additional interest in vocal cord dysfunction, mastocytositis, and mast cell activation syndrome, with a focus on improving patients' quality of life through accurate diagnosis and tailored treatments. With that, thank you, Dr. White, for being here. I will turn it over to you.
Great. All right. Thanks so much, Ruthie, and thanks to the Allergy and Asthma Network and the college for an invitation. As Ruthie introduced me, I'm at Scripps Clinic. We're here in San Diego, Southern California. I do have some disclosures that are listed here. You can see them listed for both myself and then for our moderator. And the learning objectives, also you heard, we're going to talk a little bit about just some of the basic inflammatory pathways, especially relevant to nasal polyps. We'll talk about some of the features that tie these diseases with polyps and asthma together. And then we'll talk about some treatment strategies at the end. And this is actually a challenging talk for me to put together because, including a talk that touches on both polyps and asthma, it's like such a huge, there's so many things to talk about. So I'm teasing out sort of some of the more important aspects that I think from a teaching perspective, but there's probably a lot more that I'm not able to cover. So I want to start by just focusing on the idea of the unified airway. This is an old study from 2000 that I think just does such a great job illustrating this idea of how the nose and the lungs, the bronchial tree, are tied together. So here the investigators took patients that were grass allergic. They actually did a bronchoscopy. They wedged the bronchoscope in the right middle lobe and they instilled allergen locally in the right middle lobe. And then they sampled different areas of the respiratory tree following that. So they looked in the contralateral lung. They looked at the upper lobe where they just put saline sort of as a control. And then they looked at at the nose. And that's, I think, what I want to highlight today. So you put allergen in the right middle lobe, and then if you go back in the right middle lobe the next day, no surprise, you're going to see eosinophils there. It's inflamed. But in addition to that right middle lobe that was instilled, you can also see the next day, and that's what we see here in B in the bottom right, that there's a significant increase in eosinophils in the nasal passage. So just that localized exposure could trigger distant inflammation in the respiratory tract. And you can reverse this experiment and show the same thing. You can put allergen in the nose and then subsequently demonstrate that the lower airway is inflamed. And so this is really where the concept of the unified airway comes from. The term is referring to the concept that the entire respiratory tract from the tip of the nose to the end of the terminal bronchiole all can function as a contiguous organ from an inflammatory standpoint. And believe it or not, the middle ear actually is considered in that. There's a study here. I just put the figure here on the right of asthmatic patients who had eosinophilic otitis media. And in that group of patients, they actually had only the intervention of increasing their inhaled corticosteroid to better control the lower airways. And they actually could show just by doing that, the patients would have improvement in their otitis, their eosinophilic otitis. So really kind of a fascinating way to connect this. And we really know that especially in AERD patients, they really struggle with inner ear inflammation. And that is because it is part of this unified airway. So this is a really interesting way to think about it. And everything we talk about today is going to sort of refer back to this idea. But obviously there are differences. I mean, this hypothesis can only take us so far. We don't form polyps in the lower airway. That's a disease that is really isolated to the upper airway. In the lower airway, we think a lot more about basement membrane thickening. The nose has very vascular structures that aren't replicated in the lower airway. And similarly, we've got the smooth muscle bundles around the bronchial tubes that are not relevant to the upper airway. So plenty of differences, but from an inflammatory standpoint, and I think in a relevant way for our treatment, really these things go together. There's a lot of studies also looking at gene expression. This is just one example of asthmatic children, also children with recurrent wheezing, and then children that were healthy controls. And they sampled gene expression in the nose and in the trachea. They found a tremendous amount of homology. So 91% of the gene expression was the same in both the upper and the lower airway. And genes like the keratin genes, which are going to be involved in us thinking about barrier dysfunction, which we know is such a key aspect of this disease, are not differentially expressed. So lots of similarities. Again, another example. And then if we think about the inflammatory phenotypes, we know both asthma and sinus disease dominated by type 2 inflammation, especially when we think about nasal polyposis. It's one of the things that ties these diseases together. And this is a study that's extremely highly cited from Whitney Stevens and her group at Northwestern, looking at inflammation from a T1, T2, or T3 standpoint. You can see that red here is T2, meaning that they looked for type 2 inflammation and found it and did not find type 1 or type 3. There's a lot of other phenotypes here where there's mixed patterns, but if you scroll down to the very bottom where it says CRS with nasal polyps, and underneath that, 87% of these patients have some form of type 2 inflammation. And that's about the same as what we think of in our patients with severe asthma, right? About 85% of them have evidence of type 2 inflammation. So a dominant shared inflammatory pathway, both from the upper and the lower airway. And just to remind you, in this study, because it's going to continue to come up as we try to tease out these phenotypes. Type 1 was defined by a high interferon gamma signal. Type 3 by an interleukin 17 or more of a neutrophilic type of inflammatory signal. And then type 2, of course, Charcot-Leyden crystals and eosinophil cationic protein. So I wanted to shift now to talk a little bit about the some of just of the basic concepts of how we think about polyp formation in general. Some of this is very relevant to the lower airways, and some of it is different in the upper airway. But I think it's important as we think through kind of where we're going next in our research and how we're thinking about treating these disorders. So the first concept is this idea of endogenous proteases. So we are all confronted by things that can damage the epithelial barrier. Those items like dust mites, for example, have protease content. And so the protease itself can cleave these barriers. It's going to lead you to epidermal water loss and the ability to have these substances make it deeper into the respiratory mucosa. And so, as humans, we actually have endogenous antiproteases to sort of balance that out. And one of the theories is that kind of an initial inciting event is that with these protease contents irritate the airway. And then in patients that are prone to problems, it's because they have a lower antiprotease or endogenous protease. So it's an interesting idea and way to think about it. Another concept is epithelial to mesenchymal transition. These are cells that, as they are trying to heal damage, the basal cell converts it to a different type, which is a mesenchymal form. These cells are less functional. They form kind of more, think about it almost like as a temporary bandage, but because of these mesenchymal cells, it kind of contributes to some of the dysfunction of the airway because it's not repopulating in a way that's healthy. Polyps are full of fibrin. Fibrin is actually coming from serum that's leaking into the tissues because of inflammation. And then in patients that are prone to this, under the influence of eosinophils and M2 macrophages, you're going to cross-link fibrin. Turns out that if you take a polyp out into the lab and you put a strong fibrinolytic on it, you can just shrink and dissolve the polyp. So it really reinforces how important this particular process is. And we don't think about this as much in a lot of the other allergic diseases that we treat. All right, so those are some of these key concepts of why we are forming polyps in the first place. But now we're going to talk more clinically. You know, these patients that have polyp disease, we know that polyp recurrence is not unusual. And so part of our disease control is designed to keep inflammation under control so the patients don't reform polyps after surgery. The patients can present in a variety of different ways with comorbidities. And so as we move across to the right of this arrow, you start to add things like comorbid asthma or patients with AERD or fungal disease. These patients are much more likely to recur their polyps. They're going to be more difficult to treat when compared with patients that don't have an eosinophilic phenotype. And so we're starting to get the sense of how important comorbid asthma and the unified airway is when we're thinking about treating polyps. That comes up in this study too, which is a Japanese study. This is called the JESREC study. They stratified patients into 4 categories based on the degree of eosinophilic involvement. And that was determined by peripheral eosinophil count, things like comorbid asthma, aspirin intolerance, and how inflamed the sinuses were on imaging. And what you see here on the left is the Kaplan-Meier curve for recurrence that patients that had been categorized as severe in their eosinophilic component were the most likely to recur. And then the patients that had non-eosinophilic were the least likely to recur. And so this is something that I think we've been aware of now for quite some time, and we're thinking about this now in greater detail as we're stratifying. But one of the biggest things on this list is comorbid asthma. So let's talk about this. So chronic rhinosinusitis and asthma, they frequently coexist. And this is something allergists, I think, are very comfortable thinking about. But it's different, if they think for our ENT colleagues, because they're not always thinking about the asthma component. And then similarly for pulmonary colleagues, they may not be as focused in on thinking about comorbid sinus disease. So the question here, how often is asthma a component of chronic rhinosinusitis? So the choices would be 5%, 10%, 40%, or 90%. And the answer here is the best answer out of this group would be 40%. So somewhere between probably 20 and 60% looking at the different studies. And so we could look at this both from the CRS perspective and then the asthma perspective. And so here, the blue slice of the pie are patients with asthma in the CRS population. So if you take someone who comes into your clinic, they've got chronic sinus disease, about a 40% chance that you'll find that they have comorbid asthma. The other way, it's a little less of a strong signal. So if you look at all asthmatics, it's about 20% of patients will have comorbid sinus disease. And this has been really borne out in terms of like looking at some of the registry studies for patients with asthma. You can find that the significant amount of these asthma patients in the biologic registry trials have comorbid polyp disease, and vice versa. We look at it that way. This is a study we did many years ago looking at AERD. And as you add more components to their airway disease, the more likely it is that those patients will have underlying aspirin sensitivity. So if you just look at all asthmatic, it's only about 8%. If you look at severe asthma, it's 15%. And then once you look at a group of patients that have comorbid asthma and nasal polyposis, as many as a quarter to almost a third of them will have aspirin-exacerbated respiratory disease. So again, pulling the sinuses and the asthma together and thinking about how they influence each other. So that brings us to our next slide, is how do these actually influence each other? They happen together, but does it matter? Does the upper airway influence the lower airway? And I'm sure you can see where I'm going to go with this. Here are some bullet points for the effect of sinus surgery on asthma. And I think this is a good way to tease out the components of sinus disease and how it influences asthma, because obviously sinus surgery is really going to have an effect in terms of its target just on the sinuses. It's not like a biologic where you're going to think you're going to have effects both on the upper and the lower. And so with endoscopic sinus surgery, there's even some studies that can show an improvement in FEV1. That's inconsistent, but definitely improvements in these other factors. So asthma-related quality of life, decreased asthma exacerbation rates, decreased hospitalization rates, and decreased systemic steroid use. And I think we all have seen these patients in our career, right, where kind of their asthma has continued to worsen. We find they've got significant sinus disease, and we send them for surgery, and they come back, and their asthma is a lot better as well. And we've considered that as part of the treatment for their asthma is proper sinus surgery and proper sinus evaluation. I love this study. This is a group led by Raj Sindwani. They looked at patients that had the onset of sinus disease and then ultimately went for sinus surgery. And so the very beginning of the study was the moment that first sinus disease diagnosis was entered in the chart. And then they were followed up until they had sinus surgery. None of the patients could have a diagnosis of asthma at the beginning. And so what they were looking for is how far along the way and how likely it was for patients to develop an asthma diagnosis from the beginning of their sinus disease diagnosis up until surgery. And what we see here is this really important observation in blue, that the patients had sinus surgery kind of halted the development of their asthma diagnoses. It seemed to have a disease modifying effect. And so if you look at the rate of asthma diagnosis, if the patients had not been had surgery, it's a 4.5% rate of asthma diagnosis in that group in red. Once you have this sinus surgery, the rate now drops to 0.4, so a tenfold difference. And this is for the time to to asthma diagnosis initially. So remember, none of these patients had asthma. As they're waiting for surgery, that's what we're looking for. So this is, to me, a huge effect, telling us that sinus surgery can have a disease-modifying effect purely on the lower airway. This is another study that I love to cite. It looks at patients with AERD. So remember, these patients all by definition have aspirin reactivity. They challenged all of these patients like we normally do, proved that they had reactivity. This was before surgery. So they had a full head of polyps. Then they went for sinus surgery. And then 3 to 4 weeks later, they repeated the challenge post-surgery. And only 12 out of 18 patients reacted, meaning 6 of these patients, or a third of the group, temporarily lost their aspirin reactivity simply by removing polyps. They also had a significant reduction in the prostaglandin mediator with the challenge. And so, again, another huge effect, excuse me, a huge effect of the surgery alone just having effect on aspirin reactivity, which is clearly an inflammatory stimulus. Okay, so then, the next question is, are these one disease? Is this just one disease with sort of, we're looking at it from two different places, or are these two different diseases? And I think that's a really kind of interesting question for some of our patients as we see them develop. And I've thought about, like, what are the hypotheses for how this could be, is if this is one disease. Some of the sort of, if we make a differential diagnosis, well, maybe there's something like IgE, right? If you're really cat allergic, it makes sense that that cat allergen could potentially affect the lower and upper airway. That obviously falls very short because most of our patients don't have that kind of sensitization, couldn't really explain it. So that sort of falls apart. Is this some sort of a systemic inflammation, but it's only occurring in the airway? I think there's a lot of problems with thinking about it from that standpoint. Is this some sort of a trafficking issue, like we talked about with the asthma challenge study that I mentioned at the very beginning? So you've got like eosinophil upregulation, and they're trying to get to the lung, but maybe they're also sort of being drawn into the upper airway. I think there's some problems with that for sure. The I'll share with you a slide about bitter taste receptors that are throughout our respiratory tract and are kind of an interesting way to connect the upper and the lower. And I think maybe the best explanation here is that these patients are prone to problems with barrier and barrier repair. And that's going to occur both in the upper and the lower airway. And then there may be other components of their genetics that maybe predispose them for more of an asthma phenotype versus more of a CRS phenotype. So we'll see. It's going to be really interesting as we learn more about how to think about phenotypically the patients that have asthma alone, the patients that have sinus disease alone, and then the patients that have both of those diseases together. Another study that I wanted to highlight, connecting both the upper and the lower airway, is looking at asthma or COPD related readmission rates and looking at features that increase the risk for these readmissions. So for asthma, I don't think it would be a surprise for us to say, well, if you've got comorbid allergic rhinitis, maybe that would be a factor, right? Tobacco use we see here. So some of these things we already know. But what is, to me, very fascinating is that in asthmatic patients, even having non-allergic rhinitis is a significant hazard for a asthma-related readmission within 30 days. And you could say, well, maybe this is a feature of asthma, but even that is true in COPD. So COPD patients with non-allergic rhinitis, that's an independent risk factor for hospital readmission. So this is really a striking way to say that this is not just a problem of allergic sensitization. It's not even isolated to asthma. There's something really about having the upper airway inflamed and dysfunctional, along with having a lower airway disease, that these things really are influence each other. This is a fascinating study, and I think it raises a lot more questions about what's happening there pathophysiologically with non-allergic rhinitis that's influencing the lower airway. I said I would mention the the neurological contribution. And so these are cell types, these sensory cells. They're sort of modified taste receptors, and they are peppered throughout the respiratory tract. They're wired into some of the neurologic responses, so you can have increased mucus production, for example, changes in ciliary beat frequency, et cetera. And these modified taste receptors are able to sense changes from a chemosensory standpoint. So they may sense a drop in glucose because there's a lot of bacteria around chewing up the glucose, for example. And so these are known by different names, the solitary chemosensory cells, brush cells, or tuft cells. And it's something that I think we're going to continue to hear more about. Lots of great work in helping us think through this contribution to our respiratory health. And this is just showing how these are sort of wired in. And so you can see that tuft cell on the right. You've got bacteria. The bacteria around it is triggering some sensing from that. It's going to get wired down into a sensory neuron. And then you're going to have the potential for some cholinergic effects all through that particular cell. All right, so now we're going to switch and talk a little bit about treatment. And this is something that I'm pretty passionate about, and I'll get to, some areas I think we need to try to continue to push the needle from a research standpoint. I'm coming at this again, though, kind of from the polyp standpoint. I think that's the easiest way just because comorbid asthma is so common and so clearly influential. And then we have so many treatments that are advanced therapies in this space. And so this is coming from Euphoria and just sharing kind of high level, how do we think about using biologics in patients with nasal polyps? And so if you look through the list, of course, history of surgery, if you've got recurrence, you're going to have a lower bar to starting a biologic. But one of the things that's on the list here is diagnosis of comorbid asthma. It's considered one of the features that you could use to justify starting a biologic therapy in a patient with nasal polyposis. And here again, we look through, how do we decide biologics and how do we monitor? And one of the most important things right off the top is thinking about comorbid asthma. NERD is the same as AERD. And they call out here, which I think is clear to all of us, that if you've got CRS with NP and asthma, you need to have an asthma specialist involved because you're going to be thinking a lot more about biologics and how you're going to deploy them in that particular type of patient. All right, so if we talk about treatment, do we have any evidence that topical treatment for the nose or sinuses could influence asthma? And unfortunately, we don't have much evidence at all. There is this one study that I've put at the top of almost 400 adults and children. They were treated with intranasal corticosteroids with mometasone. They had uncontrolled asthma and they had CRS, and this was a double-blind placebo-controlled trial. And treating the upper airway alone did lead to some improvements in asthma symptoms, but not a major change in FEV1 or asthma quality of life. So, there is some influence there, but that's the data that we have. Not aware of any good data for looking at sinus rinses with budesonide or using the exhale delivery system fluticasone in treating the sinuses to look for improvement in asthma. And then similarly with the steroid-eluting stents that can be used that many of our surgical colleagues use, we don't have data on that. So from a topical standpoint, we don't really have much evidence to help us in terms of connecting both the upper and the lower airway together. So we talked about topical steroids. I have one more slide I'll share on that. I'm going to briefly touch on aspirin therapy after desensitization. That will be for our AERD patients that have comorbid sinus disease and asthma. I'm going to spend most of the time talking about biologics, and I've talked about surgery already in terms of what we know in terms of influence of the lower airway. From a nasal steroid standpoint, we do have grade guidelines that I want to share. This is looking at specifically patients with nasal polyposis. IFAR states that these are better than placebo. Twice daily might have more of an effect than once daily with a small treatment effect. And then our grade guidelines that are relatively recent do recommend topical intranasal corticosteroids versus no intranasal corticosteroids for patients with nasal polyps. But sadly, we don't have as strong of evidence as we would like, and so this is actually a low certainty and conditional recommendation. What we see here are the various ways that you can use to treat. So you could have the steroid stent, the steroid spray, the steroid rinse, exhale delivery system, or drops. And then the stronger the green color, the stronger the clinical benefit. And we don't see really much harm. There's no red here on the list. So this is for the topical nasal steroids. I think we're all very comfortable with the fact that this should be a first-line important therapy for any of our patients that have CRS with nasal polyps, whether or not they have comorbid asthma. Now, aspirin desensitization, we now call this aspirin therapy after desensitization, just to distinguish that the ongoing treatment is different than the actual desensitization that takes place in the office. We've got a lot of studies now, about 1,000 patients, or I should say 5 studies. It's probably not a lot, but 5 randomized double-blind placebo-controlled trials, and then this meta-analysis by Oikman. And this is really looking at a variety of the therapies, including including the biologics. And what their summary here is that there is a strong effect on polyp growth rate, and then secondarily on sinus symptoms. It does not have a regressing effect on polyps. And so patients that are full of polyps, this is not going to be a good treatment for them. They should get surgery first. And then in terms of the unified airway and thinking about the lower airway, the effect on asthma seems to really be secondary. And so this is not, aspirin therapy does not seem to be a treatment that is going to have a huge effect if the patient's having unstable and difficult to control asthma. It's going to have a much better effect on the upper airway. Dose-dependent effect, and then, there are side effects, obviously, especially GI toxicity. About 15% of patients won't be able to tolerate being on aspirin. All right, so then we think about the biologics, and that's, where we focus a lot of our attention now because we've got a lot of options, we've got a lot of ways to think about this. And so we first have these 4 agents now that have FDA approvals for both asthma and CRS with nasal polyps. So when we're thinking about these 2 diseases together, we're probably going to be focused more on those top 4. We have benralizumab, which did not get FDA approval for CRS with nasal polyps, and they're not pursuing that anymore. And so for patients that have comorbid disease and we're thinking about the unified airway, Benra may be less good of a choice. And then everything we've really been talking about is for CRS with nasal polyps. And we've got this big, uncertainty. So what about the patients that have CRS without nasal polyps? We have no biologics that are approved for this. The only treatment that has any FDA approval is exhale delivery system fluticasone for CRS without nasal polyps. And so this really presents a challenge for us and is, I think, the next chapter in therapies for airway disease is how do we think about patients that have non-polypoid disease, non-type 2 signals, but still have that same unified airway pathology. So I'm just going to touch a little bit briefly on the different biologics, and I'm going to kind of call out both the upper and the lower airway diseases. And so remember, these are all FDA approved for both asthma and nasal polyps, so we know they work. If we look at the Dupilumab studies, the sinus studies, so this is Sinus 24 and Sinus 52, about 50% of these patients had either AERD or asthma or both. And that's important. I'm going to call that out in each of these studies because this is this unified airway population that we want to be talking about, people who have both. And so you could look down at the comorbidities, about 63% had surgery, 28% total had AERD. We know that the drug worked, had improvement in SNOT-22 score and polyp score. And importantly, in the polyp population, you can look at those patients here that had comorbid asthma and see that there is a small improvement in FEV1 and also an improvement in asthma symptoms. So this is what we want to see, right? We want to see that we're treating the upper airway, but even in these patients that have asthma, we're also simultaneously improving some of their asthma outcomes. In the polyp 1 and polyp 2 studies here, looking at omalizumab, these are the studies that led to the FDA approval here. Similarly, about a quarter of this group had AERD. So even though you're treating polyps, these patients also had asthma. In these studies, we can look at the subgroups and think about it from that standpoint. Are you more likely to get improvement in your polyps if you had comorbid asthma? And you can see there is a bit of a stratification there. Patients with AERD may have done a little bit better than asthmatic patients in general, than compared with no asthma. Mepolizumab, similar sort of analysis. So this is looking at the synapse study. And you can see that patients that had comorbid asthma did seem to have improvement in their polyp score compared with those patients that did not have asthma. So this isn't necessarily looking at asthma control in the polyp population, but it is looking at asthma as a way to predict response to biologic therapy and identifying that patients with comorbid asthma may do better. The newest kid on the block is Tezepelumab. So we've had approval for asthma for quite some time, but then just this fall, approval for CRS with nasal polyps. 17% of this study that I'm sharing had AERD, 60% had asthma. We know that it met the primary endpoints for polyp score and symptom improvement, significant improvement in SNOT-22 score as well. And here, if you look at some of the tables that are buried deep, you can see the effects of underlying AERD or asthma on response rates, and we don't see quite as much of that difference here as we did with maybe like with mepolizumab. So here it doesn't seem like that has as much of an influence, and for all of these subgroups, clearly favors tezepelumab over placebo. And then the final one, which is not yet on the market, so Dupilumab, and so this is a half-life extended anti-interleukin 5 therapy, and they have showed positive studies in both asthma and nasal polyposis. This is the polyp study, and so here 18% in their polyp cohort had AERD, 55% with asthma. And we see maybe similar to what we saw in the mepolizumab study that the presence of asthma does seem to support that the patients will have a better response with depemokimab compared to the patients that don't have asthma and don't have AERD. So, we've started to use the term remission in asthma. I'm sure everyone's familiar with this. And so that's now being extended to think about it for the sinus disease as well. And I would advocate that, a lot of these patients that have comorbid disease, we really want their entire respiratory tract to be in remission, both asthma remission and polyp remission, so full remission. And then obviously cure means that, you've had this sustained remission for 5 years off of treatment. You're no longer on any treatment. Most of the time, I think we're sort of aiming for remission as the best that we can get right now. And so I want to sort of start thinking about this because many of the patients that are coming to us in our allergy practices have both sinus disease and asthma. We know we're trying to treat both of these things at the same time. And so thinking through that and juggling through that, understanding what the patient wants is really important. And I think we need to start finding some studies that are going to help with that as well. So this is a small study from Europe. They looked at 20 patients that had severe asthma and then comorbid nasal polyps. Their asthma was under reasonably good control with a biologic. They were on either mepolizumab, omalizumab, or benralizumab, but their polyp disease was not well controlled. So these patients were then switched to dupilumab. And of the group, remember, these patients were not having good sinus disease control. And so this actually led to improvement in sinus outcomes in all of the patients. And so now we've moved from, having good asthma control, but now to having good control of the entire airway, except for one patient where their asthma worsened. And so now, we improved their sinus disease, but that particular patient now had asthma problems. And so this is, I think, really illustrates the problem that we're being faced with. We know that these drugs work for the diseases that they are FDA approved for, but many of our patients both have upper and lower disease simultaneously. And we're going to really want one treatment. The patients are going to want one treatment that does it all, right? That's the goal. And so this is, I think, where we need to have a lot more studies like this and really thinking through reasonable goals for our therapy. So we don't have a lot of studies. These are just a few that I'm going to highlight. So this is looking at Tezepelumab for severe asthma. So this is looking at the registry study for asthma patients, but many of these patients had sinus disease and had a elevated SNOT-22 score, meaning they had a lot of sinus symptoms. And so here we can see that if you take asthma patients and you put them on Tezepelumab, not only does their asthma improve, but there's also an improvement in SNOT-22 scores. So these patients were having sinus symptoms, whether or not they had active polyp disease or not, we don't know for sure. But importantly, it was improving that outcome for them. So we're treating both upper and lower airway simultaneously. And then this is another paper that I'd like to see replicated in lots of different ways and in bigger numbers. This was a European group that looked at what they called super responders. And so they took patients that had comorbid asthma and CRS with nasal polyps, and they wanted to see in their group, they wanted to identify patients that were on Mepolizumab that had essentially complete control. So they had no exacerbations of their asthma. They did not need any oral corticosteroids. Their FEV1 improved. Their ACT score was normal. And simultaneously, their sinus disease was completely controlled, and they used a SNOT-22 score of less than 8, meaning the patients had virtually no symptoms at all. And then the Venn diagram is the patients they wanted to look at that had both upper and lower airways completely controlled, and they called that super responders. And they were able to identify, actually, of these 19 subjects, that 12 of them met that definition. And they were able to do some gene expression and identify some gene signals that potentially could be unique to this cohort. And ultimately would be great for us as clinicians if we could start to identify early on some ways to predict, which biologic may lead to this super responder status. And I also think it's just important to begin to also define this and have this be a goal of therapy. If you were this patient here being on Mepolizumab, I'm sure their goal would to be into this super responder category where they virtually have no symptoms and both of their upper and lower airway diseases are controlled. This is another study that sort of gets at that. It's looking at patients that have severe asthma, that had comorbid disease, and looking at improvement in sense of smell. And in this study, they did not have access to Dupilumab or Tezepelumab, so we're looking at Omalizumab, Mepolizumab, Reslizumab, and Benralizumab. And you can see here, it's actually pretty similar across the group that there is a small percentage of patients that had complete improvement in their sense of smell, about 20% or so. Another 15 or 20% had partial improvement, and then a big part of the group did not have improvement in their sense of smell. And that's certainly something we see clinically, right? We've got our asthma patients with comorbid disease. Things seem to be under control, but they're still really bothered by anosmia or hyposmia. So that's the end of the talk. I'm going to sort of give you my thoughts on some ideas for going forward, and then I'm happy if we've got some questions or some time for discussion. But when we see these patients that have both upper and lower airway disease together, especially with nasal polyposis, our part of our job is to identify, is there part of this respiratory tract disease that's most important? And often there is, I think, right? The patients probably have both, but they may say, my sinuses are going crazy. The surgeons are sending them back because their polyps are regrowing. And so despite their asthma, we're really focused more on upper airway disease. The opposite is also true, right? We get referrals from pulmonary. The patient's been hospitalized twice for asthma in the last year. We see that they've got polyps. We do CT. We find that they've got a problem, but that's not really what's bothering the patient the most, or it's not contributing the most to their morbidity. And so in some of those patients, we're focused more on the lower airway. And then for many patients, it's both, right? You sort of look at how many times they used prednisone in the previous year, and I'll ask them like, "Well, was that for your sinuses or for your asthma?" And they're, sort of stare blankly at me like, "Well, it's for both. That happens every time I flare up. The whole thing flares up. My whole respiratory tract flares up." And so I think that's a really important thing. I would also encourage if you don't do this to use some sort of symptom or control testing in the clinic. So we do SNOT-22 scores, ACT scores, and AIR-Q scores on all of our patients at every visit. And so I am surprised at how often I will be talking most about the asthma. The patient doesn't bring up their airway, and then I look at their SNOT-22 score and it's 40. I'm like, oh my gosh, you're really symptomatic. We didn't even talk about this. Now tell me more what's going on with your sinuses. Um, I think we need more evidence and more discussion about the role of sinus surgery in a patient that has comorbid asthma. Um, I think there's a lot of potential for really great collaboration here. And as we think through kind of our workflow for surgery and biologics in patients that have polyp disease, this is going to be an important ongoing area of discussion. And then the opposite would be, the patients that we may identify in their disease course maybe earlier on that have some really significant risk factors for early recurrence of their sinus disease or of their asthma, right? Maybe we don't necessarily wait for them to fail their first surgery or have their, third asthma exacerbation and they're starting to get remodeling. And so if we could identify some of these features early on, try to get things under control and aim towards remission of both the upper and lower airway disease together. I think that's going to be a great target. So we need a lot more studies and evidence to help us as we're figuring this out. But I think it's really exciting because now we have all of these agents that have shared benefits in both the upper and the lower airway together. And so I think with that, yep, I'm finished and I'm happy. We've got a little bit of time here for questions. I'm happy to field any of them or comments if there's any comments as well.
Okay. I was getting scared. My microphone didn't want to work there for a second. We do have some questions. In regards, kind of, you were ending on the topic of a couple of our questions, which were in regards to biologics. And in your experience, how, and maybe it's more so specific to your patients, but also in studies, how do biologics compare with endoscopic sinus surgery in long-term outcomes and and quality of life of your patients?
Yeah, that's a great question. I mean, that's the question that gets to the dilemma that we're really faced with here, is like um, when you have a patient that's full of polyps and they're miserable and they've not had surgery, at that point, if you were to compare surgery to biologic therapy, how do we do that? And so, I think we know that there's a significant portion of patients that can have long-term control of their disease after surgery. And because of that, there's a big cost effectiveness argument to be made and not using a biologic that's going to be a long-term treatment for a patient if they may do well for 5 or 10 years after surgery. So that's kind of where the argument comes from. Um, so I think, we have little evidence to look at these compared to each other. There are some studies that look at biologic therapy, um, and then compare that so they'll take patients who have surgery and they look at them at 6 months, and they take patients who start a biologic and look at them at 6 months. It's not a randomized study, but they can sort of see the magnitude of benefit. And in general, it seems like they have sort of comparable outcomes in terms of what you get. Um, I think the other question is the durability of the response, and that's something we don't know. So, sure, at 6 months, we may see that these stack up the steam, but what about at 2 years and 3 years? So those are things we just don't have evidence for. But there's starting to be some um, studies looking at biologic plus surgery, and then biologic against surgery to see how they stack up.
So thank you. Another question, are there emerging biomarkers that may allow early identification of type 2 driven diseases in these patients?
There's so there's potentially going to be some gene expression. Those are things that are not going to be super accessible right off the bat, but that could be something that would be helpful. And there's a lot of work at looking at gene expression, nasal gene expression, and how it may predict response to therapies. Um, Also, something like nasal eotaxin. There are some more localized biomarkers that may also start to come up as useful for us. But I don't think we're there yet. I would encourage if you can to get your pathologists to count eosinophils in surgical tissue. We've started to do that. And so, although we don't have a hard and fast cutoff of what constitutes eosinophilic disease, having that count in there will be helpful, especially as we move forward. So even if it's like 10 per high powered field versus less than 10, something like that can be useful. There's definitely work in that direction, but we're not there yet.
Okay, awesome. There is a question if you could, it might be from more of a caregiver, provider also standpoint, but expanding a little bit more on the sinus surgery that's being done on patients that have recurrent nasal polyps. Like,
Yeah, so maybe the question is, so there's a couple ways to think about sinus surgeon. Caveat, I am not a surgeon, so I'm telling you as an allergist perspective, but there's sort of a more standard first step sinus surgery, mostly focused in the ethmoid area. It's going to debulk polyps, it's going to ventilate the maxillary sinuses and open up the ethmoid air cells. That surgery is sort of a standard surgery that is commonly done as a first step. Patients can have recurrence from that surgery. Very early recurrence, I think, would be a red flag that maybe the patient should be on a biologic. But what if it's 2, 3, 4 years down the line? And so that there's a kind of a more extensive surgery that's called a frontal drill out or a draft 3, and the surgery now kind of goes up into the frontal sinuses, which is over in the forehead, and makes the opening even wider, and can get out, more disease. And so there's, I think a consideration that a more extensive surgery could help certain patients. And I think there's debate in the ENT literature about whether perhaps patients that present with very severe disease or with ERD should have one of those more extensive surgeries. The final thing I'll tell you is something, it's a new concept that's emerged from ENT, and it's called COSI, COSI, which is called the Completeness of Surgery Index. And so I think it's a great way for the surgeons to be able to sort of more objectively assess previous surgery. And so if you had sinus surgery and then you come in a year or two later with recurrent disease, the ENT doctors now can have a scoring system and say, well, you've actually had a complete surgery. There's not more surgery to do. We should maybe think about a medical therapy versus your surgical index. Completeness of surgery is actually pretty low. There's a lot of benefit from sort of finishing the job. And so those are, I think, the ways I would think about surgery. Um, it's certainly worth always getting, as a patient, getting a second opinion, because there is a lot, I think, in the eye of the beholder from the surgeon in terms of what they think could benefit the patient. So I hope that answered the question.
yes, I think so. Well, I think that is all the time that we have for today. I appreciate your presentation and your thoughtful responses to the questions that we had today, Dr. White. In a couple of days, Zoom will email you a link with the recording as well as supplemental resources. You will also have an evaluation that is sent to you after today's webinar, as well as in the resource link that will be emailed to you. Please be sure to check out and register for our upcoming webinar in January. On January 20th, Dr. Juanita Mora will be presenting on RSV. please stay tuned for that. And as always, thank you so much for being here today and for participating in our Advances webinar series. Thank you so much, and I hope everyone has a great day. Thank you, Dr. White.